So we're 2 minutes after the hour and we have a lot of content. So maybe we will get started, everybody, as others still log on. It looks like we have excellent participation already. And so welcome to the CKD Clinic Network meeting, our last meeting of the year. And I want to start this meeting off by reflecting where I am currently taking this call. I am on the traditional, ancestral, and unceded territory of the Musqueam, the Squamish, and the Tsleil-Waututh Nation. And today we're talking about virtual health. And I must say, I'm sure all of you agree, the speed and agility that our kidney care clinics all over the country have pivoted to virtual care has been nothing short of remarkable. And we're fortunate today that we have both our provincial leads that presented last month on the call, and as well as provincial leads from BC and Ontario to talk a bit about their reflections, their experiences, and their next steps with respect to virtual care. So we can all learn from each other and hopefully forward and refine our processes. So first, I'd like to introduce my friend and colleague, Dr. Scott Grimble, who's one of the founding members of the CKD Clinic at Work, and he wears, as many of you on the call, many hats. He's a nephrologist at St. Joseph's Healthcare in Hamilton. He directs the Division of Nephrology at McMaster, and he's the provincial medical lead for multi-care kidney clinics and for First Nations, Inuit, Métis, and urban Indigenous kidney health at the Ontario Renal Network. And he's working on the virtual care strategy. So we are going to start with the Ontario experience and then move on to BC. Scott, would you like to start out for us?
Thanks very much, Monica. See if this works. Can everybody see that okay?
Yes.
Great. So I'm going to spend the next 15 to 20 minutes just kind of going over the Ontario experience, and I'm sure it'll be quite similar to what other people have experienced in other jurisdictions. As Monica said, we've all kind of very nimbly responded to obviously hopefully a once-in-a-lifetime event, but certainly some things that we all can learn from this. So in terms of the learning objectives, I'll be describing the collective Ontario experience in virtual kidney care as best as I am able, and hoping to get some feedback from all of you today to help inform the resources that we're trying to develop for virtual care in the very near future and hopefully in the long term as well. For those not as familiar with how we do things in Ontario, just very quickly, some background. So we are the Ontario Renal Network. We've gone through a lot of transformation in the last little while. We were formerly under the umbrella of Cancer Care Ontario and then CCO, and that's no longer the case. And we're a little bit more standalone under Ontario Health, which is a relatively new agency. So it's exciting times, but also very tumultuous. So we at the ORN, we provide leadership and strategic direction and obviously organize and provide the funding for kidney care services. And we help to set the standards and guidelines and quality metrics and performance management throughout the province. And we have 27 regional programs in Ontario. They're all represented by regional medical leads. We have a number of provincial medical leads, and we have regional directors as well. And so it really truly is a network, and we have patient and family advisors really playing integral parts in helping to shape policy and making those important decisions that we have to do every day. And I'm going to be speaking a lot about virtual care in the multi-care kidney clinic setting. This is called MCKC in Ontario, KCC in many other jurisdictions. And these are multidisciplinary clinics for patients with more advanced chronic kidney disease, where we do have a team of many professionals, including social work, nursing, dietitians, pharmacists, and in many other programs, others as well, including diabetes nurse educators, So a whole host of professionals that contribute to managing these complicated patients. I have to keep admitting people here to the room as I'm going here. So when the pandemic started, as Monica said, it was really remarkable when we kind of took an informal poll, and everybody very, very quickly were doing very similar things, really almost completely shutting down in-person visits, moving to virtual care, and then as time went on, trying to kind of evolve and come up with an organized approach to it. And as we've learned, and as I'll share with you, there's been variable approaches to this, but all obviously with the same goal of still providing high quality care, albeit virtually. And we also were hearing quite a bit from the programs that they were looking to the ORN to provide additional guidance, hopefully provide a little bit more direction. And there's a lot of interest in evaluating the experience, not just from the patient side, but from the provider side as well, as to how virtual care was actually going. So we've taken a sort of two-pronged approach to this. We had actually been audited by the Auditor General in Ontario, and MCKC sort of featured quite prominently. And we, as a response to the Auditor General, one of the things we had done was to develop an annual report for all the regional programs to provide a snapshot of how MCKC was going in their program. So the timing was such that we were able to incorporate a number of questions about virtual care and get that information back fairly quickly. And I'll share some of the findings from that report. And then also we have struck a virtual care task group, and I will go through some of that work. So from the annual report, sort of qualitatively, there was a number of themes that came up, or challenges that programs were facing. How to decide if a patient should be seen in person, whether they were okay to be seen virtually, was something that came up time and time again. Again, I'd be curious how it's going elsewhere, but we're all struggling still, even now, a little bit with providing multidisciplinary care. It can be quite time consuming for our patients, sometimes going beyond a day, and the coordination between the professionals often feels a bit clunky and disjointed. Technological limitations. So certainly many people are very sophisticated at home with technology, but it seems that none of them are my patients. And so technology is a barrier for many of our patients, often of lower socioeconomic class. They may be living in more rural areas where access to reliable internet is just not a given as it is for many of us here in more urban centers. We all seem to agree that video is best, but again, it's not always possible. And especially early on when long-term care facilities were effectively shut down to all visitors, trying to coordinate care with somebody perhaps with cognitive impairment or where there's language barrier, trying to reach out to them when the person that would normally be bringing them to the clinic wasn't able to be there with them. So that was another added anxiety for all of us. So going through a few of the specific domains, we asked questions about how programs determine a patient's readiness for a virtual care visit. And again, feedback varied. Many programs would, and hopefully all of them actually would obtain consent at the beginning of the virtual visit, but prior to that, there'd be pre-screening calls, often by clerical staff, to determine whether the patient did have the technology required for a virtual visit. And many programs try to help organize conference calls or three-way calls or three-way video visits for patients who really relied on family members or caregivers to assist, but who were at a different location. But some programs did admit they really had no process in place to determine if a patient was ready for virtual care. And in fact, there were some programs that had gone exclusively to virtual care, especially early in the pandemic, and really had no process to figure out whether, in fact, that would work for a given patient. In terms of in-person visits, programs again identified that they did try to keep the in-person visits fairly limited. Specific scenarios where in-person was felt to be important would be for that initial MCKC visit. If there was concern regarding a decline in patient's kidney function, where it would be important to incorporate a proper physical exam. Patients with several comorbidities, again, that's often most of our patients. Some programs were willing and able to have goals of care conversations virtually, but many felt it should be done in person. Some programs, again, were able to do modality education virtually, but many programs felt that should be in person, and discussion after the modality education to come to some decision or follow-up questions. And of course, patients who just had no way of doing care virtually. Just under half of the programs provided virtual care exclusively by phone. And while the rest of the programs did offer some form of video conferencing, they were doing it less than 25% of the time, and that was often for patient factors. And a variety of different applications were used, Zoom being a common theme as we are today, Microsoft Teams, Epic, one of the large EMRs, and OTN, or Ontario Telemedicine Network. In terms of the virtual care delivery, once the care determined who actually needed to see the patient, if it was the nephrologist, obviously, but other team members as well, the majority of the programs would have the providers conduct the visits separately. So you can imagine for a telephone visit where the nurse may call the patient, hang up, and then the nephrologist, et cetera, et cetera. And very small number of programs were able to provide virtual visits as a team. And I suspect that was primarily through video, where you could have the patient sort of sitting in that virtual room, and different team members could go into the room and then exit when they were done. Some programs have the dietitian and social worker working together to do a joint virtual visit. And all programs indicated that patients still had full access to any team member at any given visit, although again, it may happen either before or after the scheduled visit. And again, anecdotally, I think what the bit that we're missing is how patients are experiencing this. And again, we're, at least in many programs, the visit's taking more than a day. It's not ideal. Team debriefs. This finding surprised us a little bit. We asked programs if the MCKC care team had a debrief after the clinic visit, and about 2/3 of the programs said yes, they did when the visits were in person. But that number dropped to only 57% for virtual visits, where you can imagine the team members are often in different locations, and where maybe a debrief might be even more important. So that was a bit of a surprise to me. We asked them about capacity. There was a concern about access to care, and most programs felt that they were actually seeing the same volume of patients, and I say seeing in italics, as they were pre-COVID. So the total number of visits wasn't changing, just the nature of the visits. And after the first wave, as programs were trying to ramp up in-person visits again, there were some clear barriers or challenges. So often under hospital directives, there was sort of requirements about number of patients that could be in a waiting area, or social or physical distancing. So there were some challenges in terms of how many patients you could accommodate in person in clinic for a given period of time. And the infection control after a patient leaves that room, having staff available to effectively clean that room and have it ready for the next patient. And there was, frankly, some challenges with patient readiness. So I had many a conversation with my patients that I was really worried about, who were just not prepared to come into the hospital. And that was a common theme. Then we asked about sustainability. And I think people interpreted this question in different ways. The majority of programs felt that the ability to continue what they did, was sustainable, but there were definite challenges. So again, that issue of patient readiness. So If you're alternating, for example, between in-person and virtual visits, I've had so many patients scheduled for a virtual visit who showed up. So that creates some challenges. For programs that we're doing predominantly virtual visits, starting to feel a bit out of touch with the patient and not sure how they were doing. A lot of challenges. We're a lab-based specialty. If the patient doesn't get that lab work, it's very difficult to know how things are really going. And many of my patients just refuse to head to the lab for many, many months. The lack of direct access to the patient to see, volume status and just see how they're doing. Again, video is a step up from telephone, but it's not as good as in person, as you all know. And just the administrative challenges is something that programs were concerned about, and some programs had started to note a decline in their home hemodialysis rates for complicated reasons. So we did ask programs about what their thoughts were sort of post-COVID. We're all hopeful for that day. And, I like this quote here: "There's no question that virtual care is here to stay." So I think most programs are trying to ramp up their ability to provide virtual care in a bit more sophisticated way and come up with strategies to weave virtual care in so that we're not necessarily always bringing our patients in person, but having some hybrid model. But that may require some work in terms of waiting rooms, clinic flow, and space to get it right. So just to summarize the annual report, again, as we've heard from many jurisdictions, programs were very, very quick to get MCKC care delivered virtually. But there are many programs feeling that there will be some challenges long term, and that a hybrid model may work best in the short term and longer term future. Again, many barriers, and really we know very little, at least in Ontario, about patient experience about all of this. I would say by and large, our patients are very grateful that we're continuing to provide care, but whether they are perceiving that care as being high quality, I think is something we don't know in Ontario. So, as I had mentioned before, one of the other things that we were asked to do is to provide some guidance documents in the delivery of virtual care. So we have struck this virtual care task group. I won't go through all the details of the purpose. It's sort of high level, fairly obvious stuff. But three main buckets. So of course, provider resources. And again, we're not trying to reinvent the wheel here. There's a lot out there already that's more general. So we're trying to tailor this for patients with kidney disease, and in particular, the clinics that are multidisciplinary, whether it's MCKC or glomerulonephritis, for example. And we do want to have a longer term deliverable. So again, thinking beyond COVID about how programs can incorporate virtual care going forward. We've all felt our patients are not always as well prepared as we would like them for that virtual care visit. So having some resources that we can send or hand out to our patients to help get them ready for their visits is important. And then a framework for evaluating the experience of patients and providers in virtual care so that we can fine tune things again in the longer term. So the provider resource, obviously the audience is going to be for those who work in the clinics, the nephrologists, the multidisciplinary team members, but also managers and hospital administrators. And again, we wanted to keep it renal specific and practical for chronic kidney disease care. The guiding principles, again, it's obviously to provide guidance and advice on delivering virtual kidney care during the pandemic, but it's not meant to be policy directives. Shouldn't be superseding what the local hospital and clinical processes dictate. And again, it's meant to be a guidance document that can be modified locally to suit local needs. And we will be summarizing what's already out there, and again, just making it more renal specific. The major headings are listed there. So obviously an introduction, some enablers for successful virtual care visits based on feedback from the regional programs and scoping out what's happening elsewhere. some of the technology and equipment requirements, much of that's already been sorted out already. And then how to incorporate virtual care into the clinical operations. And then finally, working to help identify resources to share with our patients and their caregivers for those virtual care visits. The patient resource is still a little bit of a work in progress. Not sure how broad to go with this, but certainly we want to, again, help our patients to be ready for those visits, to optimize those visits. I'm sure we've all experienced finding our patients not at home. Maybe they're in line at the grocery store. They don't have their medications handy. They haven't had their lab work done. They haven't had a blood pressure check in 6 months. These are all things we would like to improve upon going forward. And again, so much of what I've just said kind of highlights this. So just some information for the patients and their caregivers about how the visits will be scheduled, what they require on the technical side of things, whether it's a phone or a video visit, to make sure it's so organized ahead of time. Just some practical issues related to where they should be when the visit actually happens, how follow-up takes place after the actual visit. And because there are different specialty clinics, we'll have some specific guidance for patients depending on what type of clinic that they're in. And then also, again, giving some thought to the education and training that may be required to be done virtually, to give them some information about potential links to other resources beyond what we may be providing them at each program. And again, patient experience, we're not really sure at this point what that's going to look like. It's probably going to be a combination of using a survey as well as bringing together patients in a focus group to get more qualitative information about the experience. But there also is some work being planned working with ICES in Ontario to determine what's happening with some of the clinical outcomes that may be affected by virtual care. So for example, for MCKC clinics, patients starting dialysis in an unplanned way or starting in hospital would be an obvious one. Concerns about the impact on home dialysis rates. So that's something we can kind of look at, look back in time after the dust has settled. Here are our timelines. So we do hope to have this out very early in the new year. And so the work's been underway. It's sort of, I would say, probably about 80% done now. And so the hope is to get that out early in the new year and develop a bit of an evaluation framework, and then looking into the spring, starting to think about that longer term document that will help post-COVID. So again, just to summarize, and then I'll stop. So again, all 27 regional programs have been very nimble in responding to the pandemic and continue to provide virtual care, MCKC, as well as all the specialty clinics. For better or worse, telephone is still the predominant way we've been providing virtual care. I would say few programs have mastered the art of delivering multidisciplinary virtual care in a way that's both efficient and effective. So I'd love to hear if somebody else has figured this out and can share with us. And then again, that resources for providers and patients is forthcoming. And I just want to acknowledge the two teams that I've been working with, the MCKC team, as well as the Virtual Care Task Group, which is a new body, and particularly Rebecca Lum at the ORN, who helped with many of these slides. And all the Virtual Care Task Group members, I haven't included all their names because I didn't get their permission, but you can see we are well represented by many different disciplines. So thank you. I'll stop there.
Thank you so much, Scott. It was such a nice, clear overview and a lot of common themes, I'm sure. I think for the questions, if you're okay, we'll just leave them till the end, because I'm sure some will have common themes that both speakers will want to address. So I think we'll go over to Mike. Your comment about patients with other things on the go multitasking, my two favorite are someone actually on a stand-up paddleboard out in Deep Cove that knew I was calling and wanted to take it. Not to be outdone by the driving instructor who was giving a lesson at the time, but still wanted to take the call. So it made me smile. So over to Mike. Dr. Bevilacqua is a nephrologist in Fraser Health and a friend and colleague as well. He's the chair of the BC Provincial Kidney Care Committee and also the Provincial PKD Network, and has a role in rolling out our virtual kidney care strategy in BC. So Mike, thanks for joining us.
Thanks a lot, Monica. As long as you didn't hear a car crash after that patient, with your driving instructor, you're doing all right. So you'll see there are several similar themes. Actually, all the themes are quite similar here, but between what's happening in Ontario and BC. I want to share our experiences to date. When we first talked about doing this webinar, I was assuming, by December, we'll have it all figured out and we'll have very rich data we can share with everybody and the world to be sorted. And of course, that's not the case, but happy to share, where we've gotten to by this point. Now, what I always like to do when I think about how much we've changed over the 9 months is really reflect on where we've come from. It's important because none of this was a planned change, right? We would have approached this very, very differently had we been intending to shift to virtual care. It's kind of funny. We actually in BC had it on our work plan for 2020 already to start talking about virtual care. And the way we were doing it is really cute to think about, in hindsight. We were saying, well, we might talk about doing a few visits here and there and slowly roll it in. But of course, that's not the case. Reflecting on where we've come from, it's very important to remember that we had a good thing going. I don't intend to go over evidence here. I'm just reflecting this, that we had a good system of multidisciplinary care that was shown to improve patient outcomes, had a high level of patient and provider satisfaction attached to it. We had a really, really good system before the world all kind of changed. And it's important to remember the components of this. We always use the word multidisciplinary, interdisciplinary, a renal team, and we need to kind of pull that apart and say exactly what does that mean. We do have our different care providers and we have a team, and those are actually, to me, two separate things. So we have a collection of people from different backgrounds, different professions. I've listed some here, and I'm sure I've forgotten others who contribute to the care of our patients. We're always in collaboration with each other, and we're always communicating one another. But when I say that providers and the team are two separate things, is that we don't just have a bunch of different disciplines who see the patients in kind of a parallel fashion, and then kind of somehow we get to an end product at the end. We have an integrated bundle of services with all of those providers working together. And those are two very, very different things. And it's important because when we think about how a lot of these virtual care formats were created, a lot of them really were always thought of as the one provider to one patient model. A senior family physician when you have a urinary tract infection or something like that. But we need to have room to bring in that integrated team working together if we're going to successfully import our model of care. And similarly, just like our teams are complex, there's also a lot of complexity in renal care. This is not a surprise to anybody, but we have, the way I like to describe it is we have our longitudinal care with a lot of episodes in between, our peaks and valleys kind of model of care. And within that, we have kind of buckets of services that we provide. A big bucket would be education, people newly coming into the clinic, or when it comes time to talk about modality education or transplant. Those are really intensive education sessions. There are other times when we're almost on, autopilot mode. We're in surveillance, we're monitoring, making sure everything's stable. And then when we get to acute transitions or shifts in care, there's a lot of navigation that has to happen. So you can shift from that autopilot mode to having to completely change gears and maybe hand over to a different clinic. And then between this, we have our clinic visits where the patients and the team are actually scheduled to come together and have a time to meet. But then, as a lot of you know, most of our care actually happens between those clinic visits. So it's not a scheduled thing where the whole team is there. There'll be phone calls, things will come up, and we'll have those episodes. Again, not really what a lot of our virtual care solutions were designed for. A lot of them are designed for these, single item or single task, single encounter type of model, not this kind of complexity where you might be seeing different combinations of different people in different ways. And I've gone over this a little bit, but I like to kind of list these out. The way that we do interact with them, kind of weaves in and out of each other. And I think the important thing to remember, aside from just the visits, is that we also need a way to kind of document this also. And, you know, when people kind of were making the immediate shift, this was almost an afterthought in a lot of places. And when you talk to those providers who make these virtual care solutions, it does seem to be somewhat of an afterthought for them as well. Is, well, what about how do we document both between our providers, between the external providers who might also touch the patient, and how do we make sure that we're keeping those communication lines open in the midst of all these various tasks that we're doing? So I don't need to go over all of the ways that we've kind of had to change our world, but again, it's to say that we had this really complex model of care, but somehow we had a system that worked really, really well, and we figured it out nicely, and then every single component of it shifted. We had to distance ourselves from our patients, and we had to distance our team members from each other. And some, at the beginning, we had a lot of our providers working from home, for example, not even on site. The way that our patients had to access us was frankly reduced. And I think there was both real reduced access and perceived reduced access, meaning it was kind of easy to, you know, call and know you could drop into a clinic and there'd be somebody there to meet you, as opposed to having to call and maybe have a checkpoint. At my hospital, there's physical security guards at the door to screen people coming in. It's more of a military checkpoint than it is a hospital entrance, you know, and that's obviously puts up a barrier to the way the patients come in. And then there's a lot of, you know, human factors that I think kind of flew under the radar when people were focusing on these physical ones, meaning that, you know, our patients are very diverse, both in terms of their language and culture, but also their health literacy and their ability to access technology and use technology successfully. And so too are our team members. We have some team members who, you know, took to this like a fish in water, and we had others who just had really struggled to provide care in a different way. And we have this bubbling level of kind of, I think, fear and anxiety and uncertainty amongst everybody. So I'm not trying to paint an overly complex and overly bleak picture, but I think these things are important to conceptualize just how we responded to virtual care, and more importantly, how we're going to move forward with this in the future, because I agree completely that this is here to stay. So to talk about our response, it's worthwhile painting a picture of what renal care is like in BC. Very similar to what we just heard in Ontario, actually, with maybe one big difference. So we have our provincial kidney care group, where we coordinate our care provincially and try to coordinate our resources provincially, but it is very much implemented and delivered in the local environment. And what that specifically means in BC is that we have 5 geographic health authorities. There's actually 6 health authorities, but 5, you can see the little regions there, each of which has its own structure, has its own IT PUBA, its own IT and privacy rules, and its own way of doing things that is very much siloed. So we have 5 completely separate health authorities, and within those we have actually 14 and growing clinics as we start to have more and more satellites. So we do try to always approach things provincially, but we do recognize there's of course going to be a lot of variability that happens as these actually get to the local clinics. So our approach when this all first started was to gather a working group for virtual care as well, very similar to what we just heard. And again, when I reflect back, our approach was maybe a bit idealistic, where we thought, you know, we're going to gather people from around the province. We will come up with a plan for implementing this across the board. You know we have 5 different health authorities, but seeing this situation, all of the health authorities are going to play together nicely in the sandbox. Some of them might be willing to give up some of the archaic privacy, restrictions and barriers that they've had, and we'll roll out something across the province, and we'll all be quite uniform and standardized. And then, of course, as 2020 has had a way of doing, the reality of the sledgehammer hit us, and that obviously didn't happen. But what we tried to do, as we kind of shifted gears, is say, well, let's actually have a structured plan for how we're going to approach this, and at least give some guidance to each of the health authorities. So our working group has come together, and we have a few of these living documents. You know, with the interest of time here, I'm not going to go through the details of each one of them, but I want to highlight these 2 different phases that we've essentially come up with. So we've come up with guidance for our clinics in what we call an acute phase and in what we call our restart phase. I put the restart on one side because it's the bigger document, but when this all started, remember, we actually weren't really sure what was going to happen with our clinics. And in fact, in some places of the province, we're starting to hit this again with this acute phase, meaning what happens if we have to go down to bare bones? What happens if our kidney clinic staff get redeployed? A lot of them are hemodialysis trained, for example, and we know those people are going to get snatched up if capacity, starts to be a really, really big issue. So this was the document we came up with actually at the very beginning of the pandemic, and it's now been revised again because it's becoming relevant of essentially how do we keep the lights on if our staff get taken? What are the absolute core essential tasks that a KCC must deliver, and how do we make sure that we can protect that? These documents are all freely available online, but in terms of the general content of what that includes, it's things like how do we make sure that we still have a safe way to monitor our patients' blood work? How do we make sure that we can still enable their transitions onto things like dialysis and modalities, so that can happen in a planned and controlled way rather than in an emergent fashion? And how do we still protect the core and essential visits? And then that's one side. And then what we have for what we call our restart phase, we keep changing the name. We used to call this the new normal, and everybody hated that. And I think that's a phrase that's going to be stricken from the dictionary by the end of this year. But we talk about now when you're onto more of a maintenance mode, what is it? What is our approach here? And you can see the contents that we have here. Are some of the ones that we just heard about. There's a big focus, a big part of this document is really about how do we integrate different visit types. I really like to keep promoting the term that these are hybrid clinics, they're not virtual clinics. We're not just having one way of delivering care, so how do we actually mesh those together? How do we choose our patients for the right kind of visit type, and what are some guidance that people are using? And then a lot of the practical considerations around staffing and scheduling. I'll come back to this later. I was hoping to have more to share with you in terms of evaluation to actually point to this, but right now that's still all in progress. So this is really a collection of kind of what we say the best of the best that the clinics around the province have been doing, and the consensus we've reached about how to approach these various items. We have, lastly, some documents that are patient-facing as well, that our patient partners have really, really helped with. Again, I agree completely with what we just heard, that I think we still have a lot more to learn about how do we best support our patients to do this. This first one is some more general guidance of just, frankly, what do you expect when you walk into a clinic and everybody's wearing a hazmat suit, from the patient's point of view? What to expect? How do you get ready to actually have somebody call you? I think they're very important things, and our patient partners are very instrumental in helping us with this. These are all freely available, and please do go through. And in fact, if you have feedback, let me know. So as I just talked about, as we're going forward with this, I think we really are talking about hybrid clinics. And I think that's the model that's here to stay. It's not a virtual clinic. It's not an in-person clinic. It's going to be a hybrid clinic. And, we've always had the mantra of the right treatment for the right patient at the right time. And I think now the initial layer we add on top of this is every single time we're going to have an encounter, we're thinking about what's the right visit type for the right patient at the right time. And I think if we come back to this, I think this is really the essence of all those many, many page documents is this one sentence. We've learned that our clinics absolutely can't be one size fits all. And I think that, we've now actually integrated some pretty complex decision processes for each visit, which is an added burden of work. We just talked about at the beginning how complex our care already is. And now in addition, we're asking people to assess this every time. But I think if we're, both leveraging our team, and if we're staying patient-centered with this, I think we still can get there, but this is a big shift. Right? We used to have just one kind of clinic model. We're talking about visits, and now we do have to talk about, what's our clinic going to support for each individual time the patient's coming in, what's going to be the best way to do it, and more importantly, how can we still run a big and busy clinic and not lose our care that way. So this is the part that I was hoping we would have a lot more to share, and we'd be a lot more uniform in terms of where we are. And our evaluation piece for this is just about done. And I think actually in a month, we'll have a lot more to be able to share in terms of numbers like we just heard from Ontario. But the short answer is it's widely variable in terms of what people are doing right now. And a lot of this has to do with just those differences between health authorities and between geographic areas. Some people are very limited in terms of physical visits. We never would have thought that was the case, but because of cleaning and all that type of stuff, we have some clinics, for example, where staff have had to give up their office just so that there was a place that a patient could come in and be seen because they're so short on space. In terms of our virtual types of visits, as we just heard, I would say the reality in BC is also that if you look at the province, the majority is still probably telephone, but there's a lot of granularity there. We'd have a couple of clinics that have completely replicated a previous clinic model in a virtual or video setting. And then we have others where 95% of things are done by phone, right? So there's a wide discrepancy there. The workflows have been, some people have basically tried to just import their old workflows. Some, as we just heard again, we have things spread out over many days, patients being called 6 different times across 4 different days, which is obviously never a workflow that was intended when we were designing our KCCs. The documentation is a big thing. A big number of our clinics are just all still paper-based. There is no shared electronic chart, whereas again, others have a completely electronic chart that they can access from home wearing their pajamas if they needed to, so it's a lot of variability there. And then the one I have bolded is the support from IT, which is quite discrepant as well. So our formal evaluation is still pending, but with our working group, we do meet regularly, and we do have representation from across the province. We're actually meeting again today. When this all first started, we were meeting weekly. Now we're meeting, we've got down to monthly, and I do think we have themes that we can share here, which are very similar to what we've just heard. The good, and I cannot stress this enough, is that we should all be immensely proud of our clinic staff and how far they've come. This was just absolutely unprecedented. Nobody knew what the heck was going to happen, and everybody adapted like that. I still remember having, when our first BC Renal emergency meeting happened Wednesday, and Monday we were running clinics differently. That's just unheard of. So I think we should be proud of that. I think as we're starting to gather some feedback from our patients, we're finding that some find it convenient, especially for those who are traveling long distances for clinics or have mobility issues. They can be faster. You just don't have to move someone room to room and things like that and wait for them to check in, and maybe they're late, So in a lot of times they can be faster. We found some nice supplements to our in-clinic care that I don't think we knew of before. For example, we've always had patient education sessions and things like that, but ever since moving to completely virtual, they've actually never been better attended. We have a lot of these webinars where people are flocking into, and so we have different ways of reaching our patients, mainly I think because they're just more comfortable with using something like Zoom or virtual care, so we're able to do that. And our staff webinars as well are well attended. On the downside, I think the number one is that people are sick of this. A lot of people are the shine has worn off in terms of especially those who are doing phone calls. When I'm in a clinic that's mainly phone call based, I describe myself as a telemarketer selling blood pressure pills, because that's really what I feel like some days. And, that's not what I signed up for. And that's not what a lot of providers, intended themselves doing. So, staff satisfaction, I think, is suffering. We talked about efficiency that can be gained because the visits are shorter. But in some places, we're losing all of that time, either doing IT support or air traffic control. Meaning, if you're trying to integrate in-person and virtual visits, that can be tough if people in a clinic. And if you have multiple providers doing different calls or different video calls with the patient, someone needs to coordinate that. And so we've lost efficiency there. And I think the biggest one that we heard about is forming relationships. I think when you have an established relationship, you can get by this way, but we're now at the place where, there's some patients where I've only ever interacted with virtually, and I'm not sure that I have that same rapport with them. And then, of course, there's the ugly. We know that there's some things that we just cannot do virtually. Our evaluation is, I think, going to help tease out exactly what that is. But we all know this instinctually and anecdotally, that there are some things we can't do. And even worse, there are some times that the type of visit we're having is not the type of visit we want at all. And that's a very bad feeling as a care provider, to not be able to have the type of interaction you want with a person. Some of our team members, I think, are feeling excluded, which is another really important thing to pay attention to. As I talked about at the beginning, without our integrated team, I think we lose everything. And if some people are kind of on the sidelines or are working in parallel to our team, we run the risk of losing that integration with them. It's a bit harder, I think, to know exactly what you've provided. One of the common feedbacks from our working group from the clinicians is that, at least when you're interacting with somebody face to face, you can read their body language. You know how things are going with them, if it's a good encounter or a bad encounter. When the person's in line on the drugstore, as we heard about, or, in the supermarket, you have no idea how they're responding to what you're doing or if they're engaged in the same way. And I think a lot of people have suspicions that in some times they are providing, frankly, inferior care. And the one that I think really worries a lot of us is that we might be taking some of the existing inequities and making them worse. People who already struggle to engage in our clinics, people who already have issues with their health literacy and access to care, if we've gone to a completely virtual format, we might be actually further marginalizing them. So I don't want to end on a gloomy note. I think this, as we've heard, this is here to stay, but I think that we're going to need a lot more information in terms of how we actually do properly integrate this. And what we're going to talk about is I am very happy to hear, almost identical to what we've just heard from Ontario. You know, we did this rapid and emergent shift, but now let's take stock and actually say, what does this work well for and what does this not work well for? I think that's ultimately where we need to be to select that right visit for the right patient at the right time, is to know what are the strengths, what is this really, really good for? And then the things that this doesn't work for, well, you know, we have our previous way of providing care that we can use, right? So how do we integrate the two? So this is our evaluation plan in BC, and I don't have as much details on the screen here as we just heard from Ontario, but happy to share actually what we have in our documents, where we've kind of split this into 3 different components. The one that we're kind of just finishing now is actually figuring out, just as you heard from that survey, what exactly is in place right now. We know there's a lot of variability, but we need to be able to better describe that before we can get to the next pieces. Because as we start getting feedback in terms of satisfaction from the providers, we need to know exactly what it is we're talking about. We all feel this anecdotally, but we're actually going to go back and specifically look not just how is the virtual care different, but we also know that when someone comes in physically now, it's very different from what it used to be. So how's our physical visits also changed? And we're just about done kind of taking stock of that. We're happy to share all this when it's all through. And then the part that we have planned after this is to actually talk about our experience between the patients, providers, and the teams. And it's going to be very similar to what we just heard, where there'll be first a survey and then structured interviews with these different groups. I actually specifically split out those last 2 of providers and teams. And it's not just trying to be semantics, but again, I think the individual provider experience versus how is your team functioning and what's your team morale like, I think those are 2 very different things. And I think we need to remember to take stock of both of those. I was hoping for this part there would be more standardized things already in place. We were promised in BC, we'll have a province-wide way of evaluating virtual care. I'm not sure if other places have had the same thing, but when that's come out, it's basically a survey of, did your computer work? Was your audio okay? And could you hear the person, you know, and not at all getting at the actual experience of care. And then lastly, why it's listed last is because it's going to take the longest time, is that we already have our existing metrics, things we heard like home dialysis, planned dialysis starts, things like that, but really teasing apart how is our different care modalities influence those. And I think it's going to be years before we see the real effect of that, but at least we can start tracking this now. So that's in process. I'm happy to share more of this when this is actually finished, but I think I'll kind of leave it with this so we have time to ask questions. And the last note I want to say, though, is again, just another huge thank you. The amount of work that a huge number of people have put into even getting us here is just fantastic. And I can't say enough. Everybody remember, buy a lot of chocolates for your teams around Christmas time, because they definitely earned it this year. And then maybe we'll just open it up to questions there.
Thanks, Mike. I think people are appreciating the slides, and I really appreciate the complimentary talks and the little kind of tidbits of wisdom that came from both of your presentations together. I think hearing that KCC care is more than the sum of its parts, especially on the provider level, is a key theme. I'd like to open it up if anyone has any questions, if you want to type it in or if you just want to go ahead. I think we do have some time. Can I start out with a practical one, I guess, for everybody? Have all provinces required changes to fee codes and fee structures to allow this virtual care? And if so, I'm just putting out there whether we have a way to lobby from a national format when we say it's here to stay.
And certainly in Ontario, it's happened, and if it doesn't continue, it's going to be problematic.
Yeah, and in BC, it's been the, oh, sorry, Dr. Magner.
Part of the visit, she was a no-show for me, we failed to.
In the British Columbia experience the same? There were a rapid change to fee codes to allow this. And what that means for the non-physicians is I would say about 90% of what we do now pre-COVID, the providers would not get paid for in the previous environment. And it's not that we're getting paid more for it, it's just that we're getting paid for it the same as we would have pre-pandemic. Anyone from other provinces other than BC and Ontario on the call? Okay. So it just might be some food for thought, whether once we have these documents, we might be able to leverage them together, saying that this would be state-of-the-art kidney care and we really can't go backwards. Yeah. Oh, Joanne already, yeah, Joanne says there is a virtual care code. Hopefully we'll continue. That's great. My other question was teasing out your thoughts of when you say assessing how virtual care impacts some of our hard outcomes like transitions. I think that virtual care is one aspect, but it really is how the pandemic affects our key outcomes, right? Because there's so many inputs in terms of the patient experience and what they will and what won't do, the other effector arms that are able to do things. So how to tease out the impact of virtual care versus the impact of all of the healthcare processes is something I don't know if you guys have considered.
Yeah, I think that's a huge point, Monica. And you know, one of the components of it didn't even really exist, even for kind of our wealth of information we're lucky enough to have in our database and promises. We didn't really have a way of tracking different visit types. It was never something that came up before. So I think even just, you know, we've kind of got that implemented now. And so maybe that'll help us a little bit tease those two things out. But I think you're exactly bang on that, you know, that's always going to be confounded between those two items. I think we're hoping to look at things like, you know, we're seeing at least trends in some of our indicators already of later referrals. We've also starting to see trends about home dialysis selection and conversion onto it. So I think we're seeing these trends, but you're exactly right. Picking that apart is going to be the very tricky one.
Danny from BC has commented really appropriately on, you know, a lot. It's not just the technology to afford some of these new changes. It's also things like allowing health authorities, encouraging people to work at home, and how do you bring that in, and how proactive we should be in setting up our new care models that also aren't just everyone coming back in house, and that's going to require a lot of forward thinking and a lot of kind of big changes, right? And it's a really good question.
I think the other thing that I would maybe, you know, hopefully we could lobby for as a big group is just the privacy regulations as well. We've seen a lot of flexibility in terms of staff working from home, but things around, for example, you know, some health authorities are unable to have email communication with each other. So they expect us to see all of our patients remotely. They've actually explicitly told us that, but we're not allowed to actually send anything back and forward. The health authority I work in, for example, they actually suggest that we physically mail something to the patient if we need to get them a document, which is just completely archaic. And so I think what the other one to lobby for really is maybe some unity around these privacy laws. You know, the example I always use, if I can with 2 clicks agree to do my banking online, how come I can't consent to talk to my physician and have them send me something via email?
Yeah, I would echo that. I guess, you know, the other challenge I sometimes feel, the hospitals I work in are very focused on inpatient care, and outpatient care is always kind of, you know, a secondary thing. And so, yep, you know, to the question, yeah, I mean, you know, we're always kind of clamoring for help in terms of space and you know, supporting staff, and it just always seems we're a little bit second fiddle. It's always, you know, how many days, what's the length of stay, and yeah.
And there's that question that we all ask sometimes is why is phone so widely used? Is it all technology, or are there other reasons why telephone seems to rise to the top as the most common used technology?
Yeah, I mean, my view is that you know, I talk to my transplant colleagues, and, you know, they're up to 60-70% video in the GN clinics. Similarly, as opposed to in KCC, MCKC, general nephrology. We're just nowhere near that. So I do think, the average age of my patients I've looked is about 70. So I do think it's mostly just sort of patient comfort level. Even when we've kind of cajoled a patient to take it on, we're often finding that they can't get into that waiting room, and it didn't work, and we resort to phone. Whereas my transplant colleagues love video and wonder what's wrong with me. So.
Yeah. And has COVID changed the way you interact with primary care is another question, how the KCCs and primary care interact, or should it?
Honest answer, at least the feedback from our group, and I don't know if others are finding this, is that a lot of our patients are really struggling to access their primary care providers. We find that we've actually, made ourselves more available, and in some cases we've almost taken over some of this. I think there's some who are excellent and have completely, adapted, and communication's gotten easier, but I'd say at least the wide theme we've seen here in BC is that access to primary care has gone down.
Completely agree.
All right, so we're just coming up on the hour, so I'd like to thank Mike and Scott again, and thank Selena for pulling it all together, as always, behind the scenes. There will be an evaluation form that comes out in your email. Feel free, I really encourage you to fill it out, and also provide any topics for upcoming webinars. And with that, happy holiday season, everyone. Thanks for joining.